Welcome to the Deep Dive. Today we're tackling pressure injuries, a really significant healthcare issue. You might know them by older names, maybe bed sores or pressure ulcers.
That's right. Lots of names for them historically.
Well, whatever you call them, understanding them is, well, it's crucial.
Absolutely. And our mission in this deep dive is to really get to grips with pressure injuries. We'll be using Wound Care Essentials, Practice Principles as our main guide,
Okay.
exploring what they are, how they actually develop, which is pretty fascinating. As you said, how we classify them, and maybe most importantly, how we can prevent and treat them really effectively.
And this isn't some, minor issue on the sidelines. The economic impact is just staggering. I saw a figure from 2018. The U.S. spent nearly $27 billion. Billion!
Yeah.
On hospital-acquired pressure injuries.
It's incredible, isn't it? And Medicare footed a huge chunk of that, around $22 billion.
Wow. And what really stood out to me was that the more severe ones, stages 3 and 4, they account for most of those costs. So getting this right, well, it matters a lot.
It really does. It underscores just how serious and, frankly, expensive these advanced injuries are. You'll probably also hear the term pressure injury used more often now.
Right. I've noticed that.
Especially in places like the U.S., Canada, Australia. The idea is that term better describes how they happen, the actual damage from pressure on the tissue.
Okay. Etiology. Makes sense.
Yeah, and there's a real global push for this consistent language. It helps with everything from, international coding to tracking data properly.
And to give us a solid foundation, I understand there are key guidelines from 2019.
Yes, the EPAP, NPIAP, and PPPIA guidelines. They're really key. They give us the shared definition. It's localized damage to the skin and/or the tissue underneath it. And it results from pressure or pressure combined with shear. That's a kind of sliding force.
You come back to shear, I imagine.
Definitely. These often pop up over bony areas, think sacrum, hips, heels, even ears sometimes. But importantly, they can also be linked to medical devices.
Right. Okay, so let's get into the nitty-gritty then. How do these pressure injuries actually happen? What's going on, under the skin?
Okay, so this is where our understanding has really evolved quite a bit. We used to think the main culprit was ischemia.
Lack of blood flow, right?
Exactly, just a lack of blood flow to the area. But now we know that sustained tissue deformation, think compression, stretching, and that sliding force, shear, that plays a really primary role.
Deformation. So the actual squashing and stretching.
Precisely. And this deformation can actually disrupt the structure of the cells themselves within minutes.
Minutes. Wow, that's incredibly fast. So it's not just like kinking a hose and cutting off the circulation immediately.
That's a good way to put it. That ischemia and the inflammation, they tend to come into play a bit later in the whole damage process.
Okay. So what determines who gets these injuries then?
Well, there's sort of two main groups of risk factors. First, you've got the mechanical forces themselves. How intense is the pressure? How long does it last? What type of force is it?
Pressure, duration.
And second is the individual's tolerance. And that's complex. It involves their internal anatomy, the actual properties of their tissues, their body's ability to repair damage, even things like how they regulate heat.
So what's going on inside each of us really changes our risk profile.
Exactly right. The internal stresses and strains, they're unique to each person, and they even change over time. That's why just measuring pressure on the surface, well, it isn't really enough to predict who's going to develop an injury. What's really fascinating is that this sustained deformation, this squashing and stretching, it can actually mess with how cells transport essential molecules across their membranes.
So basic cell function breaks down.
Yeah. It can lead to a loss of homeostasis, that internal balance, even if the cells aren't technically ischemic, even if they're getting some oxygen initially. Poor blood supply often becomes a secondary problem later on.
That makes a lot of sense, that the cells can't even do their basic jobs, oxygen or not, they're going to suffer.
And then, when these cells get damaged, they release signals. These signals trigger inflammation.
Okay, the body's response.
Right. And that causes swelling, or edema. This increases the pressure inside the tissues. Now, if the tissue can't easily expand, this extra pressure can deform cells even more and can start to squeeze blood vessels and lymphatic vessels shut.
So it becomes a vicious cycle, potentially worsening the blood flow problem.
Exactly. It makes the ischemia worse. There's even some new technology being looked at, like tissue biocapacitance, that might help us detect this early swelling, this interstitial edema.
That's interesting. And I read somewhere that muscle tissue is actually more vulnerable than skin. Is that right?
That's correct. Muscle tissue is indeed more susceptible to damage from this kind of deformation compared to skin.
Why is that, roughly?
It relates to its structure and metabolic rate, essentially.
Yeah.
And then, of course, you also have extrinsic factors, things outside the body but right next to the skin. It's like the microclimate. Moisture levels, temperature against the skin, these can play a significant role, especially for more superficial injuries. And then, naturally, intrinsic factors like how well blood is actually getting to the tissues, the perfusion, that also plays a part.
Okay, so we've got these mechanical forces, the pressure and shear, and then a whole host of individual factors that affect how our bodies cope. What have studies actually pinpointed as the sort of key predictors, the big ones?
Yeah, good question. Research reviews have highlighted a few key independent predictors. Mobility and activity levels are huge.
Makes sense.
Perfusion, so circulation, including related conditions like diabetes, that's another big one. And the current status of the person's skin, especially if they already have a pressure injury or fragile skin. Limited mobility seems to be almost a prerequisite, a necessary condition for these to develop.
Right. If you're not moving, that pressure just stays put. What about other factors we often hear about? Nutrition, age.
Yes, there's a whole range of other contributing factors, but the strength of the evidence varies. For instance, already having a stage 1 pressure injury or having diabetes mellitus, there's strong evidence linking those to increased risk.
Okay.
Things like poor circulation overall or an increased body temperature also have pretty good evidence supporting them as risk factors. Then there's a category with, let's say, slightly less robust evidence, but still important contributors.
Yes.
Things like having any existing pressure injury, low oxygen levels, poor nutritional status, having moist skin consistently, older age, impaired sensory perception, so not feeling the pressure.
Right, not getting the signal to move.
Exactly.
Yeah.
Even certain blood test results can be indicators. And then there are things based more on expert consensus, good practice statements. Things like having a history of severe stage 3 or 4 injuries, other skin problems, experiencing pain over pressure points, and just generally being in poor health.
It's a really wide net of potential risks.
It is, and we absolutely have to remember special populations, people undergoing surgery, critically ill patients, neonates, children. They all have their own unique sets of risks we need to consider.
You mentioned diabetes and circulation deficits. I think I saw they're particularly linked to heel injuries.
Yes, that's right. Studies specifically show that conditions like diabetes and peripheral vascular disease are significant predictors for pressure injuries developing on the heels, especially in hospitalized adults.
Okay. Let's circle back to those mechanical forces. You mentioned shear. Can you explain that a bit more, that internal sliding?
Yeah, so shear happens when forces act parallel to the skin surface, causing layers of tissue to slide over one another. It often damages deeper tissue more than superficial layers. A classic example is when someone's sitting up in bed, say the head of the bed is elevated more than 30 degrees.
Okay.
Gravity pulls their skeleton down, but friction might hold their skin in place against the sheets. This difference causes those internal layers, especially near the sacrum and hips, to stretch and distort. That's shear.
Ah, I see. So it's like your insides are trying to slide down, but your skin is stuck.
That's a pretty good analogy, yes. Then there's friction. Friction also acts parallel to the skin. It's the rubbing force.
Like dragging someone across the bed.
Exactly. Now, friction itself might cause more superficial damage, like skin tears or blisters. It doesn't directly cause those deep pressure injuries. However, repetitive friction can definitely contribute to the conditions that lead to that deeper, more damaging shear force.
Interesting distinction. So rubbing alone might not cause a deep stage 4, but it certainly doesn't help and can make shear more likely.
Precisely. Now, if we look at where these injuries typically occur, surveys consistently show that in acute care, in hospitals, the sacrum, that tailbone area, is the most common site,
Right.
followed by the heels. And interestingly, the data suggests that the incidence of heel injuries might actually be increasing. Any idea why?
It could be multifactorial, maybe related to patient populations, positioning practices, increased awareness leading to better detection. It's not entirely clear, but it's a trend worth noting. Definitely.
And we also absolutely need to talk about device-related pressure injuries. You'll see them called DRPIs or sometimes MDRPIs. This is a growing area of concern.
Device-related, you mean like from tubes or masks?
Exactly.
Yeah.
Oxygen tubing, nasal cannulas, face masks, track ties, splints, braces, anything that puts consistent pressure on the skin. The ears are actually a very common site for these.
I wouldn't have thought of the ears immediately.
Yeah, behind the ears from oxygen tubing is quite common. What's notable about these DRPIs is that they can sometimes develop faster than traditional pressure injuries.
Really?
Yes, and they're often more superficial initially, maybe a stage 1 or stage 2, but any patient who requires a medical device is inherently at a higher risk. One other key point. Pressure injuries that occur on mucous membranes, like inside the mouth from an endotracheal tube, or in the nasal passages, those aren't staged using the standard NPIAP system we use for skin.
Okay, that's an important exception. Wow, that's a lot to consider just in terms of how these injuries start. So, with all this understanding now of the causes, how do we actually go about preventing them? What are the key steps?
Prevention is, well, it's absolutely paramount, and it requires a really comprehensive, multi-pronged approach.
Okay.
The big pieces are identifying who's at risk early on, preserving skin integrity, keeping the skin healthy, addressing those underlying causes and risk factors we just talked about, actively relieving pressure and shear, optimizing the patient's overall nutrition, hydration, everything, and crucially, education for both the patient and their caregivers or family.
Identifying risk seems like the logical first step. How is that typically done? Is it just a checklist?
It really needs to be a comprehensive assessment, going beyond just using a risk assessment scale or tool. Tools like the Norton scale, the Braden scale, the Waterlow scale, they're definitely useful aids.
But I've heard of the Braden scale.
It's very common, especially in the US. It looks at 6 subscales: sensory perception, moisture, activity, mobility, nutrition, and friction shear. But these scales are just one part of a systematic assessment. We need to consider their reliability and validity for the specific patient group we're working with.
So you don't just rely on the total score.
Exactly. Current guidelines really emphasize looking at the scores on those individual subscales alongside all the other clinical risk factors we discussed to create a truly individualized prevention plan. It's not just about hitting a certain number.
That makes sense, tailoring it to the specific problems.
Precisely. You want to pinpoint what makes this individual vulnerable. Is it their immobility? Is it poor nutrition? Is it moisture from incontinence? Those key risk categories we look at for building the plan include activity mobility, skin status, perfusion oxygenation, nutrition, moisture, body temperature, age, sensory perception, certain blood markers, and their general physical and mental health.
And when should this assessment happen?
As soon as possible after admission to any care setting. And it needs to be repeated whenever the patient's condition changes significantly. How often you reassess regularly depends on the care setting and how acutely ill the patient is. It might be daily in critical care, or less often in other settings, but always responsive to changes.
Okay, so we figure out who's at risk and why. Then what? What does the actual hands-on prevention care look like?
It truly takes a team effort. At the organizational level, the hospital or facility needs systems for monitoring prevention practices and tracking outcomes, quality indicators. Are we actually doing what we say you're doing?
Right, accountability.
Exactly. Then, at the practitioner level, for nurses and other caregivers, it starts with performing a thorough skin assessment every day, head to toe, looking carefully at those high-risk areas. Bathing practices should be individualized, using gentle, pH-balanced, non-drying cleansers. And for anyone experiencing incontinence, it's absolutely vital to cleanse the skin promptly after each episode and apply a moisture barrier cream or ointment to protect the skin.
That makes sense.
Yeah.
What about dressings? I've heard about using special dressings before an injury even develops. Is that a thing?
Yes, absolutely. There's good evidence, particularly level B1 evidence, supporting the prophylactic use of soft silicone multi-layered foam dressings.
Okay.
Applying these preventatively to high-risk areas like the sacrum and heels and potentially other bony prominences can help reduce friction and, importantly, absorb and redistribute shear forces. It adds a protective layer.
Interesting. What about things not to do?
A big one is do not massage reddened bony prominences. We used to think this helps circulation, but it can actually damage already compromised tissue.
Right, okay, no massage on red spots.
And keeping heels completely off the bed surface, floating the heels, is critical. This can be done with pillows placed correctly under the calves or specialized heel offloading devices. It's important to ensure the knee maintains a slight bend, though, to avoid pressure on the Achilles tendon and potential issues with venous return.
Floating the heels, got it. What else is involved in that daily skin check and general care?
The assessment should be really comprehensive. You're looking for any persistent redness that doesn't blanch or turn white when pressed, that non-blanchable erythema we'll talk more about with staging. Also checking for edema or swelling, maceration, which is softening from too much moisture, any changes in skin temperature compared to surrounding areas, excessive dryness, any patient complaints of pain or tenderness, and changes in tissue consistency or firmness.
So it's quite a detailed look.
It needs to be. There's also some emerging technology looking at subepidermal moisture measurement as another potential indicator. And a crucial skill is being able to accurately assess skin changes in individuals with darkly pigmented skin, as simple redness might be much harder to see. You might need to rely more on changes in temperature, texture, or pain.
That's a really important point.
What?
What about moving patients?
Minimize dragging at all costs during transfers and repositioning. Always lift, don't drag. Using lifting aids, slide sheets, or mechanical lifts is highly recommended to reduce friction and shear. When positioning someone in bed, the 30-degree lateral side-lying position is often recommended to take pressure off the sacrum and hips. And unless there's a specific medical reason not to, keeping the head of the bed as flat as possible or elevated no more than 30 degrees really helps minimize that harmful shear force in the sacral region.
Okay, positioning is key. What about nutrition and therapy input?
Huge roles. Ensuring adequate intake of calories, protein, vitamins, and minerals is fundamental for maintaining tissue health and repair capacity.
Right.
For individuals identified as malnourished or those who already have a stage 2 or higher pressure injury, the guidelines suggest considering high-calorie, high-protein oral nutritional supplements. Some formulations also include specific nutrients like arginine, zinc, and antioxidants, which may further support healing, but you always need to check renal function before recommending high-protein supplements.
Good point. And therapists.
Physical and occupational therapists are vital. They work to maximize a patient's mobility and activity levels within their capabilities. They're also key for ensuring proper wheelchair fitting, including appropriate cushions and postural alignment for individuals who use wheelchairs. For people confined to chairs, the recommendation is repositioning at least hourly, with encouragement to perform small weight shifts themselves every 15 minutes if possible.
And for bedridden patients, you mentioned it's not just turn every 2 hours anymore.
That's right. The old Q2 turns rule is too simplistic. The repositioning schedule for bedridden patients should be individualized based on their specific condition, the support surface they're on, their tissue tolerance, and their overall goals of care. It might be more frequent, it might be less frequent, but it needs to be tailored.
Makes sense. And the surfaces they're lying or sitting on must be critical too.
Absolutely. Support surfaces are a cornerstone of prevention. For individuals identified as being at risk, using a high-specification reactive foam mattress or mattress overlay is generally recommended as a minimum.
Reactive foam.
Meaning it conforms to the body shape in response to pressure. Avoid those old donut-shaped devices or ring cushions. They can actually increase pressure on the surrounding tissue and restrict blood flow.
Right. Okay. No donuts.
And try to limit the number of layers of linen between the patient and the support surface, as too many layers can reduce the effectiveness of the mattress. There's also some suggestion that using smoother fabrics, like silk-like textiles or high cotton blends, might help reduce friction and shear compared to rougher materials.
Lots of little details that add up.
You really do. And throughout all of this, ongoing monitoring and clear, consistent documentation of the skin assessment findings and the prevention plan are absolutely essential. Having well-coordinated multidisciplinary teams and streamlined documentation processes have actually been shown to help reduce pressure injury rates.
Prevention really does sound like a very active, very detailed, multi-layered effort. Okay, so let's say, despite all these best efforts, a pressure injury does develop. How do we classify it? How do we describe how severe it is?
Right. So we use the classification system developed by the National Pressure Injury Advisory Panel, the NPIAP. This system describes the level or depth of tissue loss.
Okay.
Its main purpose is to provide a common language for clinicians to communicate about the severity of the injury. It's really important to remember the system is only for pressure injuries. You don't use it for, say, diabetic foot ulcers or venous leg ulcers.
Got it. Pressure injuries only.
And as we mentioned before, it's not used for staging mucosal pressure injuries like those inside the mouth. Determining the stage is generally considered within the scope of practice for registered nurses.
Huh?
Now, if a pressure injury has necrotic tissue, slough, or eschar, that dead tissue covering the wound bed so you can't see how deep it goes, it's classified as unstageable.
Until you can see the bottom.
Exactly, until that dead tissue is removed, usually through debridement, and you can visualize the base of the wound. And another really critical point, you never reverse stage a pressure injury as it heals.
All right, you mentioned that. So if someone has a stage 4 and it starts filling in with healthy tissue, it doesn't become a stage 3, then a stage 2.
Correct. It remains a healing stage 4 pressure injury. The stage reflects the maximum depth of tissue damage that occurred. Using reverse staging can be misleading about the healing process and the history of the wound.
That's a key takeaway. Is staging usually straightforward?
It can be challenging. Studies have shown that accurate staging, especially differentiating between, say, a deep stage 2 and a stage 3, can be difficult.
Yeah.
And as we touched on, there seems to be a knowledge gap for many clinicians regarding how to classify mucosal injuries correctly, remembering they aren't staged with this system.
Okay. So could you quickly walk us through the stages?
Sure. Stage 1. This is intact skin, but with non-blanchable erythema. So an area of redness that doesn't turn white or pale when you press on it.
Okay.
In darkly pigmented skin, this might appear as a different color change, maybe purple or maroon, and you might rely more on changes in temperature, firmness, or sensation compared to the surrounding area.
All right, harder to see the redness sometimes.
Exactly. Stage 2. This is partial thickness skin loss. The dermis, the layer just below the epidermis, is exposed. The wound bed is usually viable, pink or red, and moist. It might also look like an intact or ruptured serum-filled blister. Importantly, you won't see any adipose tissue, fat, granulation tissue, slough, or eschar in a stage 2.
Okay, partial thickness, no fat showing.
Correct. Stage 3. Now we're into full-thickness skin loss. Adipose tissue or fat is visible in the ulcer. You'll often see granulation tissue, which is that healthy red, bumpy tissue, and sometimes epibole, where the wound edges roll under. Slough or eschar might be present in parts of the wound bed. Undermining or tunneling, where the wound extends under the edges, can also occur. But in stage 3, you don't see or feel fascia, muscle, tendon, ligament, cartilage, or bone.
Full thickness, fat visible, but not deeper structures.
Right. Stage 4. This is full thickness skin and tissue loss. Here you have exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone in the ulcer. Slough or eschar might be present. Epibole, undermining, and tunneling are often present in stage 4 injuries.
Okay, deepest level, exposing underlying structures like bone or muscle.
Yes. Then we have unstageable. This is also full-thickness skin and tissue loss, but the extent of the damage within the ulcer base is completely obscured by slough or eschar. You can't see how deep it goes, so you can't assign a stage 3 or 4 until it's cleaned up.
Makes sense. Covered in dead tissue, can't tell the depth.
And finally, deep tissue pressure injury, or DTPI. This presents as a persistent, non-blanchable, deep red, maroon, or purple discoloration. The skin might be intact or non-intact. It can also look like a blood-filled blister or a dark wound bed if the epidermis has separated. This injury results from intense and/or prolonged pressure and shear forces, usually at the bone-muscle interface.
So it looks like deep bruising almost.
Kind of, but it's specifically pressure-related damage. And these DTPIs can evolve very rapidly, sometimes revealing the full extent of tissue loss quickly, or they might resolve without tissue loss. There's ongoing research into using technologies like diagnostic ultrasound or subepidermal moisture scanners to potentially help detect these deep tissue injuries earlier.
Fascinating. That staging system really clarifies the different levels of damage.
Yeah.
Okay, so once we know the stage, how do we actually go about treating these pressure injuries?
Well, first, it's important to acknowledge that sometimes, even when appropriate assessment, risk identification, and evidence-based prevention strategies have been implemented, pressure injuries can still occur. These are sometimes termed unavoidable.
Okay.
The wound bed preparation paradigm is a really useful framework for both prevention and treatment. It emphasizes addressing the whole patient, so managing underlying medical conditions, controlling incontinence, optimizing nutritional status, managing pain effectively, and addressing any psychosocial factors impacting the patient.
So treat the patient, not just the hole in the patient.
Exactly. Then for local wound management, the key principles are cleansing the wound, controlling or preventing infection, debridement, removing non-viable tissue, maintaining an appropriate moisture balance with dressings, ensuring adequate nutritional support, and crucially, continuing pressure redistribution. For wounds that aren't healing as expected, we might also consider adjunctive therapies.
Okay. And how do we track if the treatment is working? How do we monitor healing if we don't reverse stage?
That's where validated wound assessment tools come in. As we don't reverse stage, we need other ways to measure progress. Two commonly used tools are the Bates-Jensen Wound Assessment Tool, or BWAT.
To be what?
Yes. And the Pressure Ulcer Scale for Healing, or PUSH-H tool. The BWAT is quite comprehensive. It looks at 13 different wound characteristics. The PUSH-H tool is a bit more minimalist, focusing on 3 key parameters: the wound's surface area, length times width, the amount of exudate or drainage, and the type of tissue present in the wound bed, like necrotic, slag, granulation, epithelial.
So push-H is maybe quicker to use.
It's generally considered simpler and perhaps more practical for routine monitoring of healing or deterioration over time. We know pressure injuries often heal quite slowly, so tracking these parameters gives us objective data. High-frequency portable ultrasound is also emerging as a tool that can objectively monitor changes in the wound bed during healing.
Interesting. What about the basic principles of local wound care? Cleaning, dressings.
Okay, first step is often determining the wound's prognosis. Is it considered healable? Is the goal maintenance? Or is it non-healable, perhaps in a palliative context? This guides the treatment intensity. Cleansing is important to remove surface debris, contaminants, and loose devitalized tissue, and to reduce the bacterial burden.
What do you use for cleaning?
Generally, normal saline is recommended as the preferred cleansing solution because it's physiological and non-toxic to healthy cells. Potable tap water can also be considered in some settings if clean water sources are available. We also think about the irrigation pressure. Aiming for about 4 to 15 pounds per square inch PSI is usually optimal to cleanse without damaging tissue.
Okay. And debridement, removing the dead stuff.
Yes, debridement, the removal of necrotic tissue, that slough or eschar, is really crucial for most pressure injuries that are expected to heal. Dead tissue promotes bacterial growth and physically blocks the healing process.
How is that done?
There are several methods. Surgical or sharp debridement, using scalpels or scissors, is often the fastest and most effective, especially for large amounts of necrotic tissue. There's also autolytic debridement, where the body's own enzymes break down dead tissue under a moisture-retentive dressing. Enzymatic debridement uses prescription topical agents, like collagenase, to break down specific components of necrotic tissue. And then there's mechanical debridement, like wet-to-dry dressings, though this is generally discouraged now as it's non-selective and can damage healthy tissue. We definitely avoid mechanical debridement on clean, granulating wounds.
Got it. Lots of options there. And pressure redistribution. Still key even during treatment.
Absolutely essential. You must continue to use appropriate support surfaces, mattresses, overlays, cushions to minimize pressure on the injury site and prevent new injuries. If a patient has multiple pressure injuries, you try to avoid positioning them directly on any of them, if possible.
And dressings. So many types out there.
Yes. The goal for healable wounds is generally to maintain a moist wound environment, which promotes cell migration and healing processes. There's a vast array of dressing categories: foams, hydrocolloids, hydrogels, alginates, transparent films, etc. The key is to match the dressing's properties to the needs of the wound bed, like managing exudate, providing moisture, protecting the wound. Non-gauze dressings, like foams or hydrocolloids, have often been shown to be more cost-effective in the long run compared to traditional gauze dressings when you factor in nursing time and frequency of changes. But if advanced dressings aren't available, using continuously moist gauze can be an alternative.
Okay. And nutrition's still important during healing, too.
Critically important. Healing requires energy and building blocks. We aim for a positive nitrogen balance, which indicates sufficient protein intake for tissue repair. We need to ensure adequate calories, protein, vitamins like C and A, and minerals like zinc. Supplements might be necessary if dietary intake is insufficient.
Right. What about infection control?
We generally use clean technique for dressing changes, not necessarily sterile technique unless perhaps it's a surgical wound. Assess the wound regularly for signs of increasing bacterial burden or infection, things like increased pain, redness spreading around the wound, warmth, swelling, increased or foul-smelling drainage. If infection is suspected, diagnosis is best confirmed through quantitative tissue biopsy or perhaps semi-quantitative swab cultures using specific techniques like Levine's. Systemic antibiotics are generally reserved for when there's evidence of spreading infection into surrounding tissues, cellulitis, or systemic signs like fever.
What about topical treatments for infection?
For wounds with delayed healing, where you suspect a biofilm that's a protected community of bacteria, topical antiseptics, or antimicrobial dressings might be used judiciously, usually for a limited period, along with regular debridement. And if there's exposed bone and the wound isn't healing despite good care, you have to evaluate for osteomyelitis, a bone infection.
Okay. It sounds like a very targeted approach. Are there any other sort of adjunctive therapies that might be used for stubborn wounds?
Yes, there are several biophysical agents or adjunctive therapies that can be considered for wounds that aren't responding to standard care. Electrical stimulation actually has quite good evidence, level A evidence, for promoting healing in recalcitrant stage 2, 3, and 4 pressure injuries.
Electrical stimulation, how does that work?
It's thought to stimulate various cellular processes involved in healing, like cell migration and proliferation. The optimal parameters, like the specific charge delivered, are still being researched. Other modalities like non-contact, low-frequency ultrasound, high-frequency therapeutic ultrasound, and negative pressure wound therapy, NPWT or wound vac, may also be beneficial in certain situations.
What about oxygen therapies?
Currently, there's insufficient evidence to routinely recommend hyperbaric oxygen therapy or topical oxygen for treating pressure injuries. More research is needed there.
Okay. Any others showing promise?
Yes, things like growth factors derived from platelets, like platelet-rich plasma, PRP, or recombinant platelet-derived growth factors, and certain types of collagen dressings are showing promise, particularly for helping to heal deeper stage 3 and 4 injuries.
This has been incredibly informative, covering the causes, prevention, staging, and treatment. Before we wrap up, could we briefly touch on prevalence and incidences? How common are these injuries, and what's happening in specific settings like the operating room?
Absolutely. Having accurate data on prevalence, that's the percentage of people with a pressure injury at a specific point in time, and incidence, the percentage of people who develop a new pressure injury over a certain period, is vital for tracking progress and improving care.
Right, you need the numbers.
Yes. The NPIAP has been working on reducing pressure injury incidence since way back in 1989. Overall prevalence in the U.S. did show a decline between roughly 2006 and 2015, which is positive. However, more recently, there have been concerning reports of increases in facility-acquired pressure injuries in long-term care settings.
Okay. Any trends in the types of injuries?
Most pressure injuries reported are still partial thickness, stage 1 or 2, and the sacrum coccygiosus remains the most common site, followed by the heels. But interestingly, the proportion of reported injuries classified as deep tissue pressure injury, DTPI, seems to have increased.
Why might that be?
It could be better recognition and reporting of DTPIs, or possibly actual changes in injury patterns. It highlights the need for really clear, standardized definitions and formulas for calculating prevalence and incidence so we can accurately compare data across facilities and over time. The international guidelines provide these standard formulas.
Okay. And what about the operating room? Is that a high-risk area?
It definitely is. There's been a significant focus on reducing perioperative pressure injuries, especially since changes in healthcare reimbursement, like those from CMS in the U.S., where hospitals may not be paid extra for treating hospital-acquired conditions.
Ah, the financial driver again.
Yes. So prevention protocols have been adapted specifically for the OR environment. This includes using specialized pressure redistributing support surfaces on the operating table, using facial protection pads for prone positioning, and carefully identifying patients at higher risk, such as those undergoing very long surgical procedures.
Makes sense. And lastly, what about education and competency for the healthcare teams dealing with this?
It's absolutely critical. Accurate, up-to-date knowledge is vital for effective prevention and management. Surveys often show that nurses, for example, desire more education specifically on wound care. Knowledge levels can vary significantly among different members of the healthcare team.
And does better knowledge lead to better outcomes?
Yes. Studies have linked lower staff knowledge levels about pressure injury prevention with higher prevalence rates in facilities. Conversely, educational initiatives, wound care certification programs, they've all been shown to improve knowledge and can contribute to reducing incidence rates. There's also increasing recognition of the importance of prevention in diagnostic and interventional units, like radiology or cath labs, where patients might be immobile for extended periods. Competency checklists for pressure injury prevention skills exist and can be useful tools. And wound care curriculum is being increasingly integrated and studied in programs like physical therapy.
So continuous learning is key.
Essential. Through formal programs, conferences, online resources, Healthcare professionals really need to stay current to effectively translate the growing body of evidence into their daily practice.
Okay, to really pull all this together, let's think about a specific patient. Imagine Mrs. GK. She's 82, she's fractured her hip, and she's not really moving around much, maybe non-compliant with ambulation orders.
Okay.
She's developed a stage 2 pressure injury on her sacrum. She also has pneumonia, her appetite's poor, she's lost weight. She tends to sit up in bed most of the time on just a standard mattress. She's incontinent, her skin stays moist, and overall she looks pale, thin, her skin seems dry in her extremities. Based on everything we've discussed, what would a plan of care start to look like for her?
Right. Mrs. GK presents with multiple significant risk factors: her age, her poor nutritional status and weight loss, her immobility, the moist skin from incontinence, the existing stage 2 injury.
Yeah, quite a few flags there.
Definitely. So her care plan would need to be comprehensive. A consultation with a registered dietitian is essential, and she'd likely benefit from high-calorie, high-protein oral nutritional supplements. A referral to a certified wound and incontinence nurse specialist would be highly valuable.
Right.
Education for her family, perhaps her daughter, would be key, focusing on proper incontinence management, perhaps using moisture-wicking briefs or garments instead of absorbent pads that hold moisture against the skin. She absolutely needs a pressure redistribution support surface, a specialized mattress for her bed, and an appropriate cushion for when she's sitting up.
Right. Upgrade the mattress and seating.
Yes. And education for her son, or whoever is helping with care, on the importance of frequent repositioning, maybe using those 30-degree tilted positions we talked about, reinforcing the use of the support surfaces correctly, and proper lifting techniques. Of course, she'll need an appropriate dressing plan for her stage 2 sacral injury, aiming for that moist wound healing environment. A consultation with physical and occupational therapy would be crucial to work on improving her mobility and strength safely as her condition allows. And we mustn't forget pain management, ensuring any pain related to her hip fracture or the pressure injury itself is well controlled, as pain can limit movement.
That really paints a picture of that multidisciplinary, individualized approach.
Excellent.
Really. Before we go, let's do a quick show what you know, just a few rapid-fire questions based on our chat. You listeners can test yourselves.
Sounds good.
Okay, number 1. What is considered the primary cause of a pressure injury?
Unrelieved pressure.
2. When a patient slides down in bed due to gravity while their skin stays put, what type of damaging force is primarily involved?
That would be shear.
3. You assess a 2 centimeter by 3 centimeter pressure injury on the sacrum. You can see subcutaneous fat, there's some undermining around the edge and a bit of slough in the base, but no bone or muscle is visible. How would you stage this?
That sounds like a stage 3 pressure injury.
4. Thinking about the Braden scale for an elderly man, what score might indicate he's at risk for developing pressure injuries? A score of, say, 20 or 17?
A score of 18 or less is generally considered to indicate risk, so 17 would put him in the at-risk category.
5. Name one essential element that should be included in a pressure injury prevention care plan for a chair-confined patient.
Encouraging or assisting the patient to relieve pressure hourly or perform smaller weight shifts even more frequently, like every 15 minutes, or providing an appropriate pressure redistribution cushion.
Good one. 6. Which of the following parameters is not part of the POSH tool for monitoring healing? Surface area, amount of exudate, tissue appearance, or depth?
Depth is not explicitly measured in the POSH tool. It uses surface area, exudate amount, and tissue type.
And finally, number 7. Should a pressure injury in the mucous membrane inside the mouth caused by an endotracheal tube be staged using the NPIAP staging system? Yes or no?
No. Mucosal membrane pressure injuries are not staged using the NPIAP system.
Excellent. Hopefully you found those helpful. You can double-check the answers in Wound Care Essentials, Practice Principles.
So wrapping this all up, what does this deep dive really mean for you, the listener?
Well, I think it's clear that pressure injuries are a complex problem. They result from that interplay between mechanical forces on the body and an individual's unique ability to tolerate those forces.
Yeah, it's not simple.
Not at all. And preventing and treating them effectively demands a really thorough, team-based approach. It has to be grounded in the best available evidence, like the international guidelines, but also deeply individualized to each person's specific risks and needs. Accurate staging and careful monitoring of healing are also absolutely critical pieces of the puzzle.
And as we highlighted right at the start, this isn't a minor issue. It's a really significant healthcare challenge. It affects countless lives, and as we saw, carries an enormous economic burden. Absolutely. And maybe a final thought. Our understanding of wound care, including pressure injuries, is constantly evolving. New research emerges, technologies improve. So it's incredibly important for everyone involved in patient care to stay informed.
Keep learning.
Exactly. Keep learning. We really encourage you to explore the latest guidelines and resources. Those from EPAP, NPIA, PPPIA are excellent starting points because applying that knowledge really can help improve patient outcomes and reduce the significant burden of pressure injuries. Perhaps this discussion sparked your interest in a specific area. Maybe the new detection technologies or specific prevention strategies for high-risk groups. These are definitely areas worth exploring further on your own.